But, switching gears a little bit and on that topic related, all comers approaches and Dr. Roto, would you I know you spoke about doing a more directed therapeutic approach for EGFR patients versus a more all-comer approach. How do you decide that that treatment strategy? Is it really just, bottom line down to timing and whether or not a patient can wait, or how do you go about making that decision?
Yeah, it's a great question because I think it comes up a lot in clinic, right? We're maybe meeting and there's a set of scans. We're worried about the disease is growing. We have a conversation about maybe it's coming up on time to change therapy. And I will say for EGFR lung cancer in particular, I always want, if possible, to do that repeat profiling. And I typically do it by sending a blood test looking for tumor DNA shed in the blood. That comes back a lot faster, but it's also a lot less sensitive for picking up potential forms of new resistance. And I also like to get, and most of us will like to get a tumor biopsy, something that's growing, to actually take the growing tumor cells, feed their DNA into the same sort of test to look for new acquired genes. And that takes longer, but is much more sensitive, and can let you do things that you can't test for in blood. So not just DNA-based markers, but also protein-based markers on the cell surface. And you can look for things like tumor cell transformation to new subtypes of lung cancer, which could impact treatment selection. But certainly it's a little more involved and takes longer. So if at all possible, I try to do both these things for people who have disease progression, and I try to wait for that result because I want to know what is the what's the most personalized option for a patient. Is there something that's matched to their individual tumor that I could reach for either through a clinical trial? I agree with Dr. Cooper. If at all possible, I like to offer my patients clinical trials because I want their list of treatment options to be as long as possible. And I can make that list longer by adding not just the all-comer strategies, but if they have something on testing, a resistance match strategy, and ideally clinical trial strategies too. And I'm going to grow that list. So we have more and more lines of potentially effective treatments. So that's typically my lineup. Now, I will say that not everyone can wait for all that kind of testing. Sometimes the tumor is growing quickly, or symptomatically growing, and we just have to move on to next therapy. And then we'll use one of the all-comer strategies. Or sometimes people just don't have a good spot to get a sample. We can't have a good spot to biopsy. There's not a safe spot to biopsy. Maybe the blood test doesn't show anything. Or maybe we do all that testing and nothing comes up that we can identify. There's still that huge fraction of people who just don't have anything identifiable to explain their resistance that we can go after. And for all those settings, maybe the majority of patients in the real world, we'll do one of the all-comer strategies, and that's perfectly fine. And I'm very happy to have multiple all-comer strategies now as well.